Welcome, everyone. My name is Rachael Kupka. I'm the Acting Executive Director of the Global Alliance on Health and Pollution. And it is my pleasure to welcome you to this series of webinars that the Alliance is doing to raise awareness about lead poisoning globally and different sources of that lead exposure, different sources of lead poisoning in various regions. This is the second webinar of our series. We had one last week for Latin America. And later this week, we will have one on Africa. The topic today is sources of lead exposure in South Asia and the implications, global implications. And I am quite pleased to introduce you to our esteemed panelists today, and also would like to thank the Clarios Foundation for their support to make this webinar series possible. They have funded Pure Earth and UNICEF and are embarking on a project called Protecting Every Child's Potential, a future free from lead exposures. It's an important new program. If you haven't checked out their program and their website, please do so, and please join us. So now I am very pleased to introduce to you Pramila Sharma. She's the director for the India office of Pure Earth. Looking for her bio here. She has a degree in environmental sciences and has been associated with Pure Earth since 2005, advancing its mission to provide research support projects, oversight, management, coordination between all of the projects, the good work that Pure Earth has been doing on lead in India. So she'll get started. I forgot a few housekeeping things. Please keep your microphone on mute, and we will have question and answers at the end, but feel free to use the chat box in the meanwhile. I will be moderating and looking at that chat for the questions for the presenters. So I will be asking you to please ask your questions through the chat box. And then I will be reading those and we'll be able to ask the panelists to respond directly. So thank you. And Promila, please, over to you.
Thanks, Rachel. Okay, here I go. So I'm going to take you through the, can you see my window, please?
Yes, we can.
Oh, all right. Because it's showing me. All right. Okay. So thanks, Rachel. Thank you, everyone. I'm going to take you through the journey where we started, with identification of one single source of lead exposure. And as we, went along tackling that, we encountered another additional source, and that added to the complexity of multiple lead exposure sources that we are going to deal with now. Before I begin, let me give you a brief introduction to Pure Earth in India. We have been working in India for over 15 years, addressing public health issues originating mainly from the chemicals and heavy metals such as lead. We work very, very collaboratively with all the key stakeholders, both at the state as well as national levels, including the government, industrial bodies, researchers, academicians, affected communities, local NGOs, and others. We have prepared and handed over a national inventory of toxic hotspots to the government and have cleaned up 5 high-risk hotspots. And I'll be talking about one of the lead risk reduction project that we did in the state of Bihar in a while. So the foundation of our work was laid through our global project called the Toxic Sites Identification Work around 2009 and 10. And this is an online inventory of polluted places from the world. About 5,000 probable contaminated places have been physically verified and assessed for the exposure risk to population from the point source pollutants of concern. About 1,400 lead contaminated sites have been documented in this online database from the world. And in India, we have cataloged around 695 hotspots of various pollutants, half of which are found to be having soil or water contaminated with lead. This is definitely not an exhaustive list of all such places in India, but this gave us an idea about the magnitude of the problem of the pollution sources and led us to prioritize the emergency response. This database suggested that 75% of the lead in the population is coming from the informal small-scale operations that are located in heavily populated residential areas and marketplaces and posing serious occupational and public health risk daily.
Excuse me.
Yeah, Promila, I'm
Really?
sorry, could I interrupt you? Your slides are not advancing. So might I suggest that I share it from my screen and then you can just say next when you're on to the next one?
Or let me try sharing it again once and then you can do that. Is it visible now?
Yes, now it's advancing. Thank you.
Oh, yeah. All right. So I was just giving a background, so it's fine. I think I can continue. So I was sharing that, you know, the major sources of lead in the residential area was coming from this informal, unregulated battery recycling, which is basically, you know, the people who are on the subsistence level, they are doing these practices where they just break open the batteries, you know, with their open hammers or small little tools with bare hands. They just drain the lead-laden acid into the local sewage lines and melt open the lead plates in open, thereby causing fumes and dust in the surrounding. In the state of Bihar, in eastern part of the country, we found quite a widespread presence of such lead toxic hotspots during 2015-16. And on investigation, we found that there were several reasons. And one of the reasons were also the porous border that, you know, this state is sharing with the country of Nepal. And there was one such site which compelled us for an emergency intervention where we found a primary school with about 250 kids located next to an illegal battery plates and assembling unit in a residential area by the name Karmali Chak, located at the outskirts of Patna, the state capital. The soils around this unit was found to be highly contaminated, and now it is well known that high lead concentrations in soil and dust are linked to high blood lead levels in children. So as a very well thought of intervention, we detailed mapping and characterization of the soil around the unit, and the school was done, where we identified the key exposure route to the kids through ingestion due to their frequent, you know, hand-to-mouth activity pattern and them. Blood lead tests were also conducted in the school children and the local community to a certain public exposure to the pollutants. And on an average, around 27 microgram per deciliter was detected in 40 kids of that school. And this was almost 6 times higher than the WHO recommended limit of 5 microgram per deciliter. So just to compare, you know, among children in the US, the mean BLL is below 2 microgram per deciliter. So these elevated BLL also indicated severe neurological, cognitive, and developmental health implications on these growing kids. So our intervention after these environmental and health impact assessments included capping and covering contaminated open play areas, dirt ways, and fields, cleaning up the contaminated schools, rooms, houses, and educating the local community members about the dangers of lead sources and their exposures. Post-remediation, the soil contamination was reduced completely within the safe limits for residential soils. However, this was not the case with the result of post-intervention health follow-up testing. A nominal decrease in the average BLL in kids was noted as against the desired significant reduction. Our similar strategy has yielded, you know, 40 to almost 60% reduction in BLL in other places where we had these similar lead cleanup project, and this was like less than 10% here. So this subtly hinted at another contributing source adding to the woes of this poorly community. And This actually prompted us to investigate further the additional sources of lead, and we decided to undertake a source identification study, which happened to be the first of its kind of study in India. It was led by us, and we formed a consortium of various partners that included local development health organizations, the Bihar State Pollution Control Board, the National Center for Disease Control of the Central Ministry of Health and Family Welfare, and US CDC. So this was done to know the sources and the extent of their contamination. And given our experience of that cleanup in Karmalichak locality, it was decided that conducting this lead sources study in Patna would leverage our existing data and also our partnerships that we have established in the last 5-6 years. So in this study, the random household with children under 6 years were selected from an area located near the identified substandard informal battery recycling operations. And to compare, a control area was also selected, which was not impacted by such operations. A demographic and behavioral survey was made that included information about the child's diet, use of cosmetics, and other traditional medicines, and the potential take-home exposures from their parents' work environment. And the blood lead of the kids were also tested. The assessment of all possible lead sources in each participating child household included soil, the spices, their toys, paints on the windowsills. Cookware was done on the spot using the XRF, while best wipes, drinking water, and a subset of soil samples were also analyzed in a laboratory. A total of 136 kits were tested in the city of Patna, and a considerable and complete analysis of this quantitative and qualitative data which is being done, and a scientific paper is under review for publication. So I think it won't be appropriate for me to divulge the stats and other details, but I can certainly talk about the preliminary findings that we have observed, and it is that a majority of the kits, they had very high blood lead levels, and the significant source, aside the informal batteries, is emerging to be contaminated spices and turmeric. And I know Dr. Rahman is going to talk about, the havoc that this source has caused to the kids and people in his country. And we being neighbor, we are fearing that this is also the similar case in India. And this apparent source in India definitely needs additional investigations and analysis to know the extent of its spread and to identify the supply chain points where lead is added. Our evidence-based groundwork in India suggests 3 priority sources as on today, other than the historical lead in the diesel petrol before the phase out and the paints. And this include, as I mentioned, the substandard recycling of lead acid batteries, 50% of which is being done in the informal sector. And not just this, even among the registered facilities, the environmental performance and controls are often below the industry standards. The exposure to lead in India is most intense in hotspots around these informal battery recycling units. However, the most widespread exposures we fear may also be coming from the houses and kitchens. So the spices adulterated with either lead chromate or lead oxide pigments to give them those bright hues are found in Bihar state, and we are seeing that these are contributing to elevated BLL in other northern and northeastern states. The ceramic cookware are another source, a potential source, and not just this ceramic pottery which is glazed with lead. Even the aluminium cookware made with the metal scrap, mostly from the car parts, they may contain pollutants like lead. And adding to the complexity of these multiple exposure sources, there are other sources also which have not been yet studied and researched well, but they may be contributing significantly. And these include samples of surma, coal, the eyeliner, and certain other specialized herbal medicine formulations that deal with processed metals and minerals. And there are certain low priority sources also, such as the informal e-waste recycling, paints, contaminated water sources, and vegetations contaminated with growing in contaminated soils and being irrigated with contaminated waters. So I'm happy to share, as I conclude my presentation, that Pure Earth has already initiated strategic interventions that requires a multi-year engagement and synergies between various multiple agencies. And we have been able to get endorsement from a high-level government agency called Niti Aayog, a government think tank, and research institutions such as the Council for Scientific and Industrial Research in India, as well as National Environmental Engineering Research Institute, to name a few. And in the next couple of years, we are going to work at understanding the severity and geographic distribution of exposures through monitoring and blood lead testings in high-risk states that we have identified. Equally important is analyzing the simultaneous contribution of various sources through home-based assessments, particularly in the highly exposed households. So as a strategy, we are going to work on that also. And this is going to help us in prioritizing key significant sources and designing targeted specific mitigation interventions to each pollution sources. These programs will be complemented with the public awareness campaigns and ongoing monitoring to evaluate progress as we march ahead. And on this note, I think I should stop and welcome questions at the end of the presentations round. Thank you.
Thank you very much, Promila, for that eye-opening presentation. And we can see that the sources of exposure are multiple, and it's very important for us to be able to work out where they're coming from for each individual child that's going to be treated. I have the pleasure now to introduce Dr. Paromita Hore. She's an environmental health scientist with the Bureau of Environmental Disease Injury Prevention in New York City, Department of Health and Mental Hygiene. Dr. Hore has been providing technical assistance to that bureau on issues related to characterizing environmental exposures, including environmental sampling and analysis. And more recently, she's been overseeing the Bureau's investigation of hazardous consumer products in New York City. And that has led, her work has led to the removal of thousands of lead-contaminated consumer products from New York City businesses. Dr. Hore has her doctorate and master's in public health from Rutgers and has been with the New York City Health Department for more than 15 years. We look forward to your presentation.
Thank you. Thank you, Rachel. Good morning, good afternoon, good evening, based on wherever you are today. It is a privilege to be able to present on this topic to a global audience, and thank you to Global Alliance on Health and Pollution for coordinating this panel. So as Rachel mentioned, I work at the New York City Health Department and oversee our department's work around lead-contaminated hazardous consumer products. And today I'll speak to you about our findings in New York City around some traditional consumer products from South Asia that have been found to contain high levels of lead, as well as been associated with lead poisonings in New York City children and adults. So before let's see if I'm okay, it advanced, hopefully. So before I delve into the various products we've seen, let me give you a brief background on how we learn of these types of products in New York City. So in New York City, blood lead testing is required by law for certain populations. For example, children at the ages of 1 and 2 years of age are required by law to be given a blood lead test by their provider, as well as pregnant women during their first prenatal visit are required to be assessed for risk for lead exposure. And if deemed at risk, they are supposed to get a blood lead test. And workers with lead exposures, workers that work with or around lead, are also required to be monitored by their employers. And we at the New York City Health Department, we get all the blood lead reports for all of the New York City residents, and that amounts to hundreds of thousands of blood lead reports annually. And we at the Health Department, we investigate cases with elevated blood lead levels to find out what the lead source is for these individuals. And the follow-up investigations entail interviews, as well as environmental testing, which can involve also testing of consumer products that are collected during these case investigations. And this data is routinely monitored, and it helps us to understand which communities are more at risk to lead exposures within the city, as well as what their risk factors are. And so what our surveillance data shows us is that in New York City, South Asian children and adults have a disproportionate burden or overrepresented amongst our lead poisoned cases. So here illustrated data for children on the left and pregnant individuals on the right. So if you look at the childhood data, whereas the percent of Asian children citywide is 14%, among our cases with elevated blood lead levels, 23% of the children are Asian, and majority of these are South Asian kids. Similarly, on the right, for pregnant cases, while only 5% of the live births citywide were to mothers born in Bangladesh, India, Pakistan, 19% of the pregnant cases were to women of South Asian descent from Bangladesh, India, Pakistan, and Nepal. So we at the City Health Department have investigated numerous cases of lead poisoning in South Asian children and adults. And while lead paint hazards are the most commonly identified source of lead exposure among New York City's children, lead poisonings within this community, within the South Asian community, both children and adults, have been associated with use of certain traditional consumer products found to contain high levels of lead. And these include spices that were purchased abroad or sent from South Asian countries such as Bangladesh. We've seen spices such as turmeric and chili powders found to contain extremely high levels of lead levels up to 10,000 parts per million. And lead may be added to these spices intentionally as a coloring agent or unintentionally due to introduction during processing. We published a paper in 2019 that summarizes our spice data, looks it over for a 10-year period between 2008 and 2017. And during this period, we collected almost 1,500 spice samples, and as part of case investigations or New York City local store surveys. And what we found was that the average lead content in spices was significantly higher for spices that were purchased abroad versus those that were purchased in the United States. And our data also showed that the spices with the highest lead concentrations purchased came from the country Georgia, Bangladesh, Pakistan, Nepal, and Morocco. So based on our findings, our advice to South Asian New Yorkers is to purchase these spices in local New York City South Asian shops or shops that are selling these types of products, and avoid use of hand-carried products from their home countries or sent from abroad. Regardless, a lot of cases do report bringing the spices from abroad. It really illustrates the ultimate solution is control of the lead source at the country of origin or countries of origin. We've also seen lead poisoning cases associated with certain Ayurvedic medical medicines. And Ayurveda, as you may know, is a traditional holistic system of medicine from India, and not all Ayurvedic medications contain high levels of lead or other metals. But Rasa Shastra Ayurvedic medications are intentionally prepared with metals, minerals, and gem compounds. And we've seen cases associated with these types of medications that were either handmade or manufactured prescribed by a practitioner or purchased over the counter in the United States or in other countries. And we've investigated cases with blood lead levels as high as 192 microgram per deciliter. Compare that to the reference blood lead level that Promila mentioned, the 5 microgram per deciliter. And we've seen products with lead concentrations upwards of hundreds of thousands of parts per million, and some also with extremely high levels of arsenic as well as mercury. So users are not always able to tell apart between Rasa Shastra Ayurvedic medications as well as versus the purely herbal Ayurvedic medications. So our advice to New Yorkers is to speak with their doctor about getting a blood lead test if they are using Ayurvedic medications. And we also encourage healthcare providers to ask their patients about use of prescription or non-prescription complementary and alternative medications such as Ayurvedic medications. And if use is reported, we encourage them to test the patient for blood lead or urine mercury or urine arsenic. And lead poisoning cases associated with Rasa Shastra Ayurvedic medications have been seen nationally and worldwide. It's not solely a local issue. We've also investigated lead poisoning cases in children and adults associated with the use of Kahol Kajol Surma. Kahol Kajol Surma may be used by children and adults for various reasons, cosmetic, medicinal, or as a religious powder. And we've tested samples with concentrations of lead as high as 98% lead. And there is significant potential for hand-to-mouth exposure to lead from these types of products as they are applied topically. So given the cultural sensitivities around these types of religious and cultural powders in New York City, our approach has been to encourage risk management steps, such as washing hands after use, keeping away from children, speaking with their doctor to get a blood lead test if using these products. And we've also seen lead poisoning cases associated with the use of sindoor, a religious powder used in Hinduism. We know that not all sindoor contain high levels of lead. However, users cannot usually distinguish between those that contain high levels of lead versus those do not. So again, given the cultural sensitivities, a risk management approach is encouraged among users. Wash hands after use, keep away from children, seek a blood lead test if using such products. We've also seen lead poisoning cases in children associated with the use of certain amulets or tabis or metal charms. And these products may be used for various reasons: protection against evil, good luck, and so also speech therapy. Here are some examples highlighted, some of the examples from case investigations we've conducted. Tabis used to stop child from crying, a shisha that was actually given to a child to mouth for speech therapy, and a tabis from India, so Bangladesh and India. The children, when they're mouthing these types of products, as children often do, mouth many things, they can get the lead into their body through that process. So our advice to New Yorkers is keeping amulets such as these away from children whenever possible. However, if the children do wear an amulet, place it in a way so that the child cannot mouth the item. We've also seen extremely high levels of lead in samples of kasa and brassware. And eating food or drinks stored or prepared in these types of products can introduce lead into the body and can be a contributing factor for increased body burden of lead. So in New York City, we use a comprehensive approach to address these types of lead sources. Once we learn of a potential lead source from a case investigation or literature, we survey New York City stores to determine availability of these types of products. We conduct sampling and testing of the products. And if found to contain elevated levels of lead or other heavy metals, We then use a multi-pronged approach, which incorporates both enforcement as well as education and outreach to remove these types of products from the marketplace, as well as raise awareness about the potential lead exposure risks to these products among the community. So we are routinely conducting activities to raise awareness among New York City South Asians about the potential lead exposure risk associated with the types of products we discussed. But the challenge continues to be behavior change, as many of these products are culturally ingrained. So although I presented data from New York City investigations, this is not a local issue. Our jurisdictions within the United States have also reported similar findings. And as Promila described, they're seeing these abroad in India as well. So today's world is connected, we know this, with ease of travel and ease of access to such consumer products. So a lead source, once identified, needs global intervention involving evidentiary data, dialogue with stakeholders, increased enforcement, and ultimately with source control at the country of origin. So again, I thank you for your time today, and we look forward to our continued dialogue on this topic.
Thank you, Dr. Hore. I'm, as you're going through your presentation, I'm going, wow, oh, and I've heard you make presentations before, but some of the findings are truly shocking. And of course, the point about it being global in nature is really well taken, and is one of the reasons why the Global Alliance on Health and Pollution is so concerned about being able to reduce the sources, at the actual place where the contamination is being introduced to a product, in the case of spices or these other things. So thank you very much for your presentation.
Thank you.
Yeah. I now have the pleasure to introduce Dr. Mahbubur Rahman. He's a graduate with a master's in public health and population sciences, and more than 22 years of experience in public health research in Bangladesh. Dr. Rahman has been leading environmental interventions unit at icddr, a local Bangladeshi organization, which employs a team of public health professionals, epidemiologists, anthropologists, social scientists, and statisticians. Dr. Rahman has also been leading research work at icddr on lead contamination, e-waste, water and sanitation, water salinity, and other environmental health issues. Please, over to you, Dr. Rahman.
Can you see my slides?
Yes, we can.
Thank you so much. So we knew from the presentation that there are multiple exposures from different sources of lead. So I will focus only on spices, and especially turmeric. You can see here how the turmeric grows and different stages of turmeric. So there are a lot of toxins in the environment, but lead is particularly bad. I want to discuss the recent work that we did, as well as we already very familiar with another invisible environmental toxin, that is arsenic. So lead is also a metal. It has impact on human health. It has impact on cardiovascular disease. It has impact on endocrine diseases, as well as it harms in many organs. It is a particular bad actor. Lead directly affects heart, you have known. It affects the brain of the mother, a parent, but it also affects the brain of a developing children. And this is a particular concern for us. So food safety issues are becoming a rising public health problem around the world, particularly in low and middle income countries. Adulteration of food is one type of danger in which substances are introduced to improve the perceived quality of a food. Spices are one of the most regularly adulterated foods, since they are costly commodities that may be easily mispresented when sold as powders. in a database over 1,000 records of food adulteration worldwide from 1980s to 2010, spices accounted for 11% of all entries, with many of them containing harmful color additives such as carcinogenic Sudan dyes. Turmeric, also known as golden spices or Indian saffron, due to its brilliant yellow color, is an essential culinary spice consumed daily in South Asia. Turmeric is relatively a root of ginger. Primarily, it grows in India, Bangladesh, Myanmar, China, and Nigeria. Let's go back to the study that we did. What benefit in Bangladesh? We conducted a large trial, integrated interventions to see the impact on child growth and development. In this cohort, we evaluated the severity of lead poisoning as well as identify the pathway of exposure. The study enrolled approximately 6,000 pregnant women during their first and second trimester of pregnancy. And we randomly selected subset of that cohort and assessed for blood lead level. And interestingly, we found that 31% of the pregnant women had high blood lead level that we never imagined, because these women, they're living in the rural Bangladesh. So how they are exposed to the lead? It is actually turned out to be a very hard to think human lead to a particular exposure. This is thus the hard scientific problem. It is hard because lead gets stored in bones and they can stay there for decades. It has some equilibrium with the blood. So current lead levels may or may not reflect exposure that are recent exposures that are maybe long ago. So it's non-environmental epidemiology. This is really a hard problem. So we engaged anthropologists, epidemiologists, environmental scientists, and geochemistry analysis to explore these issues. And then we try to understand this better. And most importantly, we used a very qualified and dedicated team, those who work hard for this. And our initial investigation found that in Bangladesh, like the rural people, they don't expose to gasoline, no paint in homes, no glassed water, and we did not find lead in the traditional medicine. So what happened there? So there are two related questions, like, is there lead in the environment? Are people exposed to this lead? We exposed to this pregnant women, trying to understand their behavior and practices. And we tested the samples like household, whatever they have been using in your daily life, including agrochemicals, pesticide, rice, other food materials, spices, so that finally we come out 3 environmental sources that people are contacted in rural Bangladesh. That is lead solid cans, soil, as well as turmeric. You might remember, as Paromita was talking, that recall in the US, we get interested because on lead, because we found that there are 9 recalls on 13 brands of turmeric in the US. All of them came from India and Bangladesh and distributed at least to the 7 countries. And all of them are exposed to lead. So, considering all of this, we met with the colleagues from the agriculture department to understand in which district in Bangladesh they grow the turmeric and mostly produce it as well as process it. And we found that almost 9 districts in Bangladesh, they produce the turmeric. And we collected the samples from all these 9 districts, as well as like that there are different sources of the supply chain, and we analyzed for lead by using the ICPMS. And interestingly, we found out of 9 to the 7 districts samples that contains lead. And you can see that The samples we have found with the raw turmeric root was always clean. Raw turmeric root was never contaminated with detectable lead, but if we look at the polished root, many of the samples are contaminated. Similarly, the bulk ground turmeric, there were many samples, those are contaminated, and even some of these packaged turmeric was contaminated. And we found that turmeric from Dhaka and Munchiganj, close to like the capital, had more lead than turmeric in other districts. So overall, like you can find that 20% of the samples that we collected had high blood lead level according to the Bangladesh food safety standard. So this is really alarming. So we also looked at the supply chain. So the team then went to visiting the turmeric polishers to figure out what was going on. And you can see here some pictures showing of the yellow pigment that was identified in many places, and we found few polishers who added yellow pigment in 7 of 9 districts. And we tested this powder. All the turmeric and all of the yellow pigments contains both elevated lead and elevated chromium concentration. So the lead in turmeric was lead chromate, it proved. Across all study districts, we collected samples, pigments, and each of type turmeric available at major wholesale as well as to the retail markets. We collected samples from turmeric powder, unpolished, polished, dried turmeric root, and pigments, and also sampled dust inside and below polishing machines to assess how lead chromate-based pigments have been added, as well as 3 soil samples from the within 5 to 50 meter radius around the polisher's mills to determine how far the lead contamination may have spread into the surrounding environment. So let's see a video. You can see here that a gentleman here who is demonstrating so that some of the puree powder, locally called it like a puree powder, the lead chromate mix powder. So there he is mixing the powder directly with the raw root and so polishing it to improve its color. So you can see here, so there are 4 different isotopes of lead. So it is all lead isotope, just have different number and neutrons of slightly different weight. So I am talking about this because you have seen that, we found lead in turmeric as well as other spices, as well as we found lead in pregnant women blood. So how we will decide that the lead in the pregnant woman blood is coming from lead or is from soil or other sources? So the ratio of lead isotopes can indicate the age and origin of lead. So sources of lead might have like a distinct isotope ratios. So you can see here the isotopic ratio between lead and turmeric is almost similar, and so lead salted cad as well as soil and clay, you can see the differences. So that from here you can say that the lead in pregnant women blood as well as lead in turmeric, both of them matched by the isotopic test. So who and why basically mixing this lead chromate with the powder that they use for polishing? Our qualitative team, they went to the major turmeric producing district and interviewed 10 to 20 people within the supply chain in each district. Then what they found was that some of their customers preferred bright yellow turmerics It's that you like the turmeric not only because of the flavor, but the color is permanent, and the polishers said they added lead chromate at the request of wholesaler so that they can sell it easily. You can see one of the interviewer, he's telling, here is a man has some nice turmeric from Khulna districts that basically grow the best turmeric, and that looks like yellow. A polisher from the southeast said that if turmeric gets wet in the rain, no matter how you polish, good color would not come out. Then you have to add color in order to sell in the market. A polisher from Southeast said, those who know turmeric, they will always buy colorless turmeric. On the other hand, those who only go by looks, they will buy colored turmeric. Colored turmeric goes to like a capital cities as well as big cities, and there is no demand of turmeric with color activities in the local areas. So based on all of these findings, we discussed with the team, engaged the stakeholders, and identified the strategies for the interventions. So how and what we did, we planned to engage in educating the wholesalers, polishers, as well as general public, increase testing by the Food Safety Authority and regulatory steps, engaging electronic and print media, advocating to restrict import of lead chromate, recommended people purchase whole unpolished turmeric, explore low-cost turmeric dryers and testing, and exploring import of food-grade yellow dye. So you can see that evidence and engagement makes difference. It was really hard to make understand to the colleagues from the government without any evidence. So we had the publication with us for all of this evidence. We shared with the Bangladesh Food Safety Authority, with the print and electronic media, and make them understand this is a real problem. At the same time as Paromita was presenting, the New York Bangladesh Embassy also reported to the Prime Minister Office about this recall. So even the Prime Minister Office, they gave the guidance to the Bangladesh Food Safety Authority and Bangladesh Commerce Ministry to work on this, as well as we integrated lead intervention with other ongoing programs. So Bangladesh Food Safety Authority published the public notice, distributed educational materials, held stakeholders meeting, regulatory steps taken by the Food Safety Authority with the support of icddr. As I said, that Prime Minister Office also took necessary steps to guide the different ministries, as well as we collaborated and developed the monitoring plan, how we can handle this. You can see that print and electronic media, how they basically prioritize these issues and published in the newspapers almost for weeks. So we also measured the progress and recorded it like that before the intervention, as well as after the press release and other event conducted by the Bangladesh Food Safety Authority, electronic and print media. And we found that 47% of the samples in fall, before the news release, are tested for positive. And after the intervention, we found a very small percentage, 5% were positive for lead. So it's really a great progress, as well as we have ongoing surveillance system to measure the situation and report to the government. Another way we try to work on this, in order to a disincentive lead chromate adulteration in the long term, we are motivated to improve the turmeric drying and turmeric quality in Bangladesh. Traditional open sun drying can result in compromised turmeric quality. As a result, we are proposing to test and improve dyeing techniques. We work with the Bangladesh Agricultural Research Institute to try this, and we have been working on this with the farmers as well as Bangladesh Agricultural Research Institute, as well as our collaborator with Stanford University. So we hope there will be some good results from on this. So Let me go to at the end what we have learned from this work. Turmeric adulteration is a predominantly regional problem. Portable XRF testing is advantageous as non-destructive and provides a rapid measurement of multiple elements simultaneously. Availability of alternative food-grade yellow powders might help consumers unable to accurately assess the quality of powdered turmeric. Awareness about yellow pigment adulterated turmeric is low among consumers and food safety alike. Engaging relevant departments from the government, private sector, print and electronic media contributed meaningfully. Continuing surveillance to assess the evidence of late comment across the turmeric supply chain benefited, as well as need focus on developing, implementing and evaluating interdisciplinary approaches to reduce the exposure. And recently our team, they received an award on the Food Safety Day for this great work on reducing the lead contamination in Bangladesh, especially from the turmeric. We have a great lead team, those who have been working for a long time. And we thank all of our collaborators, our partners for contributing for this work. And thanks everyone for hearing me. Thank you so much.
Thank you, Dr. Rahman, for that very interesting presentation, and also to be able to learn what some of the interventions are, because of course we want to be able to protect children's health, and to do that we definitely have to get to the source. So thank you for highlighting that very important example, and I see a very active chat happening, and Promila saying, well, that will be interesting to be able to apply to India, as I can imagine other countries will also be interested to hear that case study and success. So I now am pleased to introduce Lesley Onyon, who comes to us from the World Health Organization here in Geneva, who works with the Chemical Safety and Health Unit. Lesley is a toxicologist who has worked for more than 25 years in fields relating to chemicals management, poison information, occupational environmental health, both in the UK and Australian government, as well as with WHO, previously UN Environment, and also previously OECD. She recently took up her post at the Chemical Safety and Health Unit at WHO here in Geneva, after having moved from the regional office of Southeast Asia in New Delhi. So I'm sure she's got some very good stories about lead exposures in India for us. But in her new position at WHO, she has a particular focus to support WHO's activities related to the poison centers, chemical-related aspects for emergency preparedness, and normative work concerning prevention and management of heavy metals, particularly lead and mercury. And I know WHO has been doing a lot of good guidelines and information, so I look forward to hearing your presentation, Lesley. Thank you. Over to you.
Thank you very much, Rachel. I'll just try to share my screen. And that's not the right one. You share. So, okay, can you see my slides now? I think you should be able to.
Yes, it's just starting to come up. Yep, there's a bit of a delay, but please go ahead. Thanks
so much. And I'd like to congratulate the earlier speakers. They certainly were very interesting and presentations which show some of the overlooked sources of lead. So they were very, very informative. My presentation will focus a little bit about what we're doing at WHO, particularly on the prevention and management of exposure to lead. Our activities really focus in three areas: on the technical information, on partnerships, and campaigning and advocacy work. As earlier speakers have attested to, the health effects of lead exposure are very many. It's a multi-system toxicant with no known level of exposure without harmful effects. Because it mimics calcium and iron in the body, it has many effects in different body systems and accumulates in the bone. Long-term effects include reduced intellectual capacity, antisocial behavior, cardiovascular and renal disease in adults. And the onset of symptoms are sometimes insidious, such as anemia and colic. And so often we see that healthcare providers often are not immediately relate the symptoms to exposure to lead. So whilst we know quite a bit about the health effects of lead, we're still aiming to improve what we know about the public health impacts. And we like to refer to the knowns and unknowns of chemical exposure, and refer to this tip of the iceberg situation where we know a reasonable amount about a very small number of chemicals. The best estimates that we have were released earlier this year, with 2 million lives and 53 million disability adjusted life years lost due to chemical exposure in 2019. But nearly half of those deaths are attributed to chemical exposures from lead, particularly resulting from cardiovascular disease. So we know a reasonable amount about lead. We probably don't have the whole picture, but compared to many other chemicals, we have a much better understanding about lead than other chemicals. And our colleagues in UNICEF estimated that 1 in 3 children worldwide currently have a blood lead concentration greater than 5 micrograms per deciliter. So WHO is very clear in classifying lead as a major public health concern. There are 10 chemicals which we put in this overarching category, and they're listed here. But lead is certainly one of our main focuses in terms of advocacy and technical information, particularly as shown on this slide. The most vulnerable amongst us, children, are disproportionately affected. So we have, for each of the chemicals that we classify as a major public health concern, we have developed a number of WHO technical publications, question and answers, and fact sheets. And here are a few examples from those relating to lead. And the exposure to lead, a major public health concern, pulls together all of the WHO more in-depth technical information that exists, which has come from various sources, but notably from the Eject for Food Additives series, where the last update confirmed that there was no safe level of exposure. In addition to technical information, we're working with our member states, that is the ministries of health in all of the 194 countries, to better inform them of the impact of chemicals on health, and that includes the impacts of lead. And we have developed through the World Health Assembly a resolution on the role of the health sector in chemicals management, because often when we talk to ministries of health, they're unsure of their role in this area, because most of the interventions to control the sources of chemicals exposure lie outside of the health ministry itself. But in spite of that, there are a large number of things that the ministries of health can do, not only to advocate, but also to implement prevention and management guidelines, and also to work with other ministries. And we've been putting a lot of emphasis on the phase out of lead paint, and encouraging ministries of health to really work together with ministries of the environment and others on that issue. Our work on the elimination of lead paint is undertaken very much together with the United Nations Environment Programme, and we have a global alliance to eliminate lead paint, for which 70 governments and organisations are partnering with us. This has been established following the Intergovernmental Conference on Chemicals Management in 2011, with the objective of preventing children's exposure to paints containing lead, minimising occupational exposures, but with a broad objective to phase out the manufacture and sale of lead paints. we have an annual campaign, and you'll see the campaign logo in the top right-hand corner there, ban lead paint. So that couldn't be really more clear as the objective that we're working towards. Since 2019, we've been fortunate to get additional resources from the Global Environment Facility, and that has further enabled us to focus on providing technical support to some 40 countries to establish lead paint laws in their countries. WHO also has a global health observatory where we pull together information on different health-related topics. And one of them in the public health and environment section of that repository concerns data regarding legally binding controls on lead paint. So we've surveyed countries every year to track the progress being made on this issue. And the most recent survey that has just been completed shows some improvement, and now we have 43% of countries having laws. But you can see that for the many countries in Africa and in Asia still yet have to have binding controls on lead in paint. So we continue to work with those countries and others to improve that situation. So as I mentioned, every year, WHO coordinates an International Lead Poisoning Prevention Week. This itself is an initiative of the Global Alliance to Eliminate Lead Paint, and further acts to galvanize actions worldwide. The first campaign was in 2013, so this is the 9th time that there's been an annual campaign on this issue. We have a WHO campaign website which provides a platform for events all around the world to be registered. And last year, it was some 90 events were registered. So it shows that the interest in countries in advocating for further work on lead paint and other lead exposures is certainly very much active. And we're very glad that the Global Alliance for Health and Pollution have organized today's meeting as part of the campaign activities. WHO, together with UNEP and other partners, have made a number of campaign materials available, and these are customizable logos, different banners, posters, etc. And you'll find them on the campaign website. So our slogan for this year is working together for a world without lead paint. Shown, and the picture on this slide shows the landing page for the campaign website. This is some of the examples of the information materials that are available. Guidance on organizing an advocacy or awareness raising campaign, the communication materials, including customized flyers, posters, different technical information, such as the status of lead paint laws, technical and policy briefs, guides to the analysis of lead in paint and lead in blood. And we try to make the information as widely available as possible in all 6 UN languages. As part of the campaign this year, WHO will be releasing some new guidelines for the clinical management of exposure to lead. And this will be launched on the 28th of October, so next week. We see this as a really significant development because it's for the first time we're providing evidence-based recommendations to physicians and other healthcare providers about the diagnosis and treatment of lead exposure. This will include an interpretation of blood lead levels, recommendations for gastrointestinal decontamination when someone is eating a lot of lead flakes or some solid lead objects that can get lodged in the gastrointestinal tract, as well as recommended chelation therapy to enhance the elimination of lead for severe poisoning. And there are guidelines for the 4 essential antidotes, succimer, penicillamine, sodium, calcium, editate, and dimercaprol, as well as recommendations for nutritional supplements, notably calcium and iron. So these new guidelines, as I said, are a significant development. We're focusing at the most vulnerable. And so specific treatment recommendations are given for children under 5 years of age, pregnant women, lactating mothers, and adults with high blood lead levels. For each of the recommendations, you'll find a detailed rationale and also considerations for implementation of the recommendations, because that obviously is of prime importance. We get a lot of questions about, what levels of lead should be associated with what activities. And as we said before, that WHO recognized there is no level which is considered safe. The recommendations in this particular new set of guidelines will say that for individuals with blood lead levels more than 5 micrograms per deciliter, the sources of exposure and appropriate action to reduce and terminate exposure are the most important step that can be taken. When I said that the recommendations also detail use of the chelating agents and so on, those recommendations don't generally come in until much higher levels, for example, 45 micrograms per deciliter, or when there are severe signs of lead poisoning existing. So the most important recommendation is that based at all individuals with levels more than 5 micrograms per deciliter, the sources of exposure and reducing and terminating that exposure are the most effective measure that can be taken. As I said, we are launching these guidelines on the 28th of October, and you can register to attend that launch. It's an open event where you'll hear more details about the guidelines, and there'll be plenty of time for question and answers at that session as well. I think that's my last slide, so thank you very much. Here is a link to the Lead Poisoning Prevention Week campaign page, and if you have any questions, you could send them to this No Lead in Paint at WHOINT or to me personally. Thank you very much.
Thank you so much, Lesley. It's very important to look at the examples that we do have that are working, and the challenges even in something like getting lead out of paint, which is working really well, but still remains. And so as a prevention technique, getting rid of lead in paint is absolutely essential. So clearly, as we have seen from the panelists, we really have, as a global community, enormous challenges ahead of us to fight lead poisoning globally. But with no safe level of lead exposures and 1 in 3 children having elevated lead levels at the moment, it's absolutely imperative that we as a global community come together to fight these sources of lead poisoning and to work with the private sector to try to get lead out of different products and food and spices, and to work with the private sector as well to clean up practices. So we heard from Pramila Sharma about the complexities involved with examining affected communities and the multiple sources of exposures. Dr. Rahman spoke about how hard it can be to trace sources of individual high, elevated blood leads, especially if they're historic or in the past, and how the complexity of how lead impacts our body, which Lesley brought to light, as well as Dr. Rahman, really highlights kind of further the challenges that we have. But Dr. Rahman and Promila also provided us some really important examples of how we can strategize to get around this, and highlight the existing sources and find those sources so that we can reduce the impacts and prevent childhood lead poisoning and exposures. I would like to encourage our participants here to ask questions in the chat. But while I see a few things happening here, and I think there was one person that had their hand up, I wonder if I might kick off the discussion and question and answer session here to think about how we can actually intervene and how we get people excited about working on lead and reducing the sources of exposure. And specifically, my question would be at this point, in terms of interventions, Promila and Dr. Rahman gave us some examples of how they're working with the private sector. And so to Pramila and perhaps also to Dr. Hore, how might interventions or similar approaches with the private sector work for other sources? And do you have anything in the works and planning?
Yeah, I can say a few things, at least from New York City's perspective, as we talked about. Many of these types of sources that we're seeing are coming from abroad, elsewhere, right? So one of the strategies we have used is we've notified our embassies or consulates. We work through our consulates to notify the foreign ministries of health. And we have these opportunities. For example, we've had an opportunity to have dialogues with Dr. Rahman as well as his team, because our strategy is to inform the ministries of health at the countries of origin so that they are able to take or address the issue. So, and locally within our communities, we are continuously conducting education outreach activities to raise awareness amongst the communities at risk. But ultimately, I believe the source control would be the ideal solution.
Thank you, Dr. Hore. Promila.
Oh yeah. So in India, so we are beginning to understand, the scale and extent of the contamination sources as spices. And we are fortunate that, a number of private, institutions and charitable organizations are coming forward to support that kind of investigation work. But from the experience of engaging and working with the private sector led battery recycling associations in the past on dealing with the informal battery recycling as a major source, our experience is very positive. The industry, they are quite forthcoming in supporting and encouraging their members, particularly the registered recyclers, to work out to basically use the standard and the best practices in extracting those metals from their plants. And at the same time, they are those associations are working with us, and they're willing to be a part of solution going forward as we plan to form a kind of national led advisory group in future to participate and give recommendations for intervention that will include not just regulatory changes, but also the support for economic solutions. So basically to do away with the informal sector, businesses. So I would say the private sector is equally encouraging, and in India, it's a good thing that the current government is pretty proactive, and they are listening to this issue, and this is being highlighted, and they are listening to us and giving us a platform to endorse this work.
Thank you, Promila. That's great to hear, and thank you, Dr. Hore. There's a question for Ms. Onyon. Do you have any evidence that the implementation of lead paint laws can reduce children's blood lead levels?
Thanks. It's a very interesting question. I think that most of the evidence comes from precedents in other areas where we've shown that removal of significant sources of exposure does have an impact on reducing blood lead levels, certainly on a population-wide basis, and that evidence is from the fact that removal of lead compounds from petrol, gasoline, where following that action, certainly very widespread reductions were seen. Certainly on an individual level, when a child is being chewing on lead flakes and so on, then obviously there's a direct link there. But on a population basis, it's largely to do with these with examples from with removing significant sources of lead exposure. So undoubtedly lead paint has been a significant source of exposure in many countries for decades, going back to the 1920s when the ILO brought into place, its first convention on lead paint. And certainly the work that's been done in the US and in Australia and Europe, they have shown further decreases after getting lead out of petrol. So I think, as one of the speakers mentioned, it's very hard to, when you have multiple sources of exposure, it's very hard to attribute reductions to a particular source without a significant forensic effort, that, as was described by Dr. Rahman. But we see once this sources of exposure are eliminated one by one, we do continue to get population decreases. So I think that's the evidence that we have.
Thank you, Lesley. Yes, just like it's difficult to identify the sources, if there are multiple, it can also be very difficult to attribute any reductions unless you're quite clear that there was really only one source and that source has been reduced. So we have some more questions in the chat from Ramchitra or Charitra. What are the contribution of all these sources of blood we have talked about today to the high blood levels found in the Pure Earth report? I think that's the Pure Earth Toxic Truth report done with UNICEF in 2020. Promila?
Yeah, so I think it's very difficult to answer this relative contribution of all the various sources that that has been reported under this Toxic Truth report, and that's one research gap which is there, and I think the research community, not just in India, world over, has to work on it. But so far, in the lead contamination and poisoning cases are going very, very case specific and region specific. So in a way, like in one area, you might be finding one or two as sources as the key contamination source, and dealing with those significantly reduces those implications. So that's my sense on that. Yeah.
Thank you, Promila. We have another question for Dr. Hore. Could you provide some detail of the Nepalese contest you have mentioned in your study? So maybe the context, it might be a typo.
Right. So I think one of the top demographics that are showing up within our pregnant cases happens to be also from Nepal, other than Bangladesh, India, and Pakistan. And some of the lead risk factors for this community off the cuff, as I recall, some spices as well as sindoor has popped up. But I can gladly follow up with you offline. But again, the various lead risk factors for this community sometimes overlap. But I think sindoor and spices jump out for the Nepalese.
If there's any further, if there's anyone here that wants to really have a think through some of these different sources and implications for different regions or countries, please feel free to reach out to us at the Global Alliance, and we'll be happy to introduce you to a variety of different people through emails or the best we can with our network. I'm looking now at the chat to see if there's anything else. I see Syed has his hand up. But Ram Charitra, you had your hand up for a while now. Was there anything in addition that you'd like to add to the discussion or questions from our panelists?
Yeah, thank you for giving me this opportunity. Actually, I thought there was no scope to raise the thing, so I charted it. But however, I come from Center for Public Health and Environmental Development and heavily engaged with this lead-related research and advocacy campaign. And last year, we have also tested few cosmetics for the lead, like mascara and then lipsticks and eye products. and we have found some of them are really contaminated with the lead. So we have been doing all those things, but a large scale of those kind of study is needed. And as I proposed also one of the things in the chat, I think we at a regional level should work together for at least eliminating the major source of lead in different products. And one way would be listing of lead pigments or other leaded compound in Rotterdam Convention Annex 3rd list of chemicals, so that we can regulate its import export under PIC, prior informed consent mechanism adopted by RC Convention. So that is one way, as speakers from Bangladesh said, it is not possible to ban the import export, some kind of things, what I have understood related to lead products. So I think RC Convention would be one of the best venue for all of us to intervene with from our country level and also from the regional perspective. Thank you.
Thank you. I see one more question in the chat, and let's go to that, and then to Syed Moshfiqur Rahman, please, after that. The question is to Lesley Onyon: does the WHO have standards to assess lead in samples other than blood? So, for example, in urine or other medium.
Other than, sorry, just.
Other than
blood. Yeah, well, blood is the medium which is the definitive gives the biomarker of lead in blood. So we focus on that as the recommended measurement. Other than lead in paint, where we've been doing some work with UNEP and other partners to promote different methods of measuring lead in paint and painted surfaces. We don't have other recommended methods.
Yeah, blood lead levels remain the most useful at the moment.
Yeah.
Syed Moshfiqur Rahman, please.
Thank you giving me the opportunity. I'm just I don't write in chest because little bit bigger discussion I'm to raise is that. Thank you, Lesley. You are here from WHO and from other organization. But as a part of Bangladesh policy level or stakeholders level, I'm just developing the guidelines and other some part. But interestingly, we are working for this toxic like lead and other toxic metal because I'm working mainly cadmium, arsenic, and even pH. But what are the intervention are you consider for the community level or the community awareness? Because still we are at even the clinician, they don't know that lead is a toxic thing for the children, how they can prevent it. Even so how you are involving the professionals, especially health professionals, and how you are involving the community, because those who are real in problem, they don't know these toxic elements and pollutants. And as because what I just mentioned, that the strategy development, child health, and still although I'm in Sweden for last 10 years working as an associate professor in Uppsala University, but still I'm trying to motivate in Bangladesh the people to work in the stakeholders to toxic environment and pollutants and toxicant. But what I found, the gap between these professionals, stakeholders or government people and researcher, at the same time, you NGO people, those who are really working, suppose you are working a lot in the on lead part and something, but I found there is a gap between the professionals and you. So how we can integrate these issues by WHO, maybe we can respond on
it. Yes, I completely agree with that, what you've said there. And I think that too often as toxicologists, we're we're very excited by what we're working on. We talk to other toxicologists and so on. We might want to learn more about the mechanisms and so on. But I think it's still very difficult to get the message out to the whole range of different health professionals, which might be in a position to detect either some source of lead exposure or some behavior or some symptoms that could be associated with that. So one of the measures that we'll be taking in follow-up now to launch of these guidelines is to having a much more active and systematic approach to training of different healthcare professionals. We have numerous examples of children who've been seen for anemia and so on, and the health professional needs to be prompted to ask about their living arrangements, what their occupations of their parents are. And I think that the approach which Paromita described, where in New York it's very much a sort of systematic, institutionalized process, that would be fantastic if we all had those resources to be able to follow up like that. But certainly we need to be getting through to the maternal and child health development people, nutritional experts. It's not just so that we can spread the information about the sources and the things to look out for, the questions to ask, and so on. And I think that this new information that's been, it's very new to me, I think, in terms of the other sources which have been shared from this region are very important, because I don't think that enough of evidence has been published on some of these sources. I know that we've heard from some of the main published, the main scientists which are working in the field at today's session, but I think that we need to be doing a lot more in terms of gathering the evidence and finding how widespread these particular sources are to spread the word.
Thanks.
If I may add something,
Yeah,
sorry.
please go ahead.
Absolutely agree with you, Mr. Rahman, that it is quite a challenge. We're reviewing all this information all the time, sharing with foreign ministries, trying to communicate to the community where the risk factor lies is very much a challenge. But here too, we try to routinely send alerts and have dialogues with healthcare providers and work with community organizations, community-based organizations. If we can get buy-in from them, they are in the community speaking with the families. But I think ultimately it will take time. We are collectively having a dialogue, which is very exciting. We in New York City, it's a melting pot, so we have been able to identify some of these types of sources, but then it's exciting for me and others within the department to be able to have this global platform to have these dialogues and continued dialogue. So hopefully, ultimately, there will be a solution, right?
Thank you, Paromita. I wanted to mention, following on what Lesley has saying about the importance of getting baseline data. A lot of the countries that we are estimating are most impacted by lead have very little data actually on lead exposures that's been produced by local research institutes or published in scientific journals and things like that. Dr. Rahman, is there anything in addition that you'd like to add? There is one more question that we can go to before we close out, but I did want to give you the opportunity to respond to some of the questions that have been posed thus far.
Yeah, thank you so much. One important thing is that even we have been working on lead issues. So many people even don't know lead is a problem. There is a problem. So like that, when we have started talking about the turmeric powder, so that when the people know first time, even the clinician, practitioner, they started sending their turmeric samples to our office. So like people don't know basically this is a problem. That's we need to inform all the people. Second thing is that we have policies, like we have a lot of policies. And many of them even never implemented. It's in the document. So like that, that's another problem. And third thing is that engagement, like that, whom to engage, how to engage, who can contribute. So all this we need to identify and engage them. That's another important issues, because like the Commerce Ministry, they don't bother about the health issues, like that. Other, even the print and electronic media, they are not well oriented about these issues. Even then, if you want to talk with the government without having any evidence and published document, even it's always difficult to say something to the media. That's another challenge. So these all are basically we need to address together. Otherwise, like we cannot make it happen. That's, I feel like that we need to focus on these issues. As well as the roadmap that we are developing, like along with all the partners, so that we have a great plan even for implementation, how we are doing this. So all these really important issues. So I feel that now time to start working on this to make it further level. And another question was like that, how we will monitor all this? Like the other surveillance, if we don't have this surveillance, how we will say that people are not mixing lead chromate today, whether they will mixing it tomorrow or not? So we need basically ongoing surveillance system to monitor this if we feel that this is an important issue. So like, I feel that these are the things we might need to consider, not only for a country specific, maybe for region specific, because just an example like that, there are a lot of turmeric coming from India, Myanmar to Bangladesh. Even we found that this turmeric also contains lead. So we need to address this regionally, not like a local. Thank you.
Thank you, Promila. I see you've got your.
Yeah, so I was meaning to say that perhaps WHO and Global Alliance, with global presence, should take a lead, and the forces should join to create this mass awareness, particularly in low and mid income countries. There is this need of, the public demanding for this. And hopefully, post COVID-19, this threat is over. The government in all the countries, they have this good sense of now recognizing this issue and start creating mass educational drives using various media. And I think this is actually required. The public awareness in India, for example, is too less. And the success stories of the campaigns for eradication of polio in our country, as well as currently the air pollution, the way it is being highlighted, and the various sources, I think something like this has to be worked out down the line, and the forces should join. And that includes everybody, not just the community groups, but also the medical professionals, governments, and everybody.
Good. Thank you, Paromita. Thank you, Pramila, Dr. Rahman, for your comments. I would like to mention, just before we wrap up here, though, we do have one last question, is following on the call to bring different types of stakeholders together. The Global Alliance on Health and Pollution will be launching a global lead coalition with the name to be confirmed yet, with this exact intent to bring together a variety of stakeholders to talk about the different types of exposures to lead, to look at examples that have worked in the past, particularly looking at other awareness campaigns that have been really, really effective, to bring those forward. And we will be sending out some information quite soon on that. The other thing, following on what Dr. Rahman said, which is, how are we actually going to monitor this? One of the things that the Alliance has been thinking about is how we might be able to promote the inclusion of blood lead levels, for example, as an indicator in the Sustainable Development Goals. That would be, we can only measure what we're being asked to measure, and many countries don't even have the ability to measure blood leads yet. So that's something that we look forward to discussing in the international community, and have had several discussions with Lesley about brainstorming and thinking on that. So our last question before we wrap up is to Dr. Hore. It says, it was mentioned that stop sale or distribution of products was an intervention model for contaminated consumer products. Is it really feasible? Could you share a little more?
Yes, so I was in the middle of typing. So just very quickly, we at the New York City Health Department have the authority to take enforcement actions and stop businesses from sale within our jurisdiction if they're found selling hazardous consumer products. And also we routinely send our findings to share with other jurisdictions as well as the federal jurisdictions. If it's a food, drug, or cosmetic, it will be the US FDA or Food and Drug Administration. And that has resulted in incorporation of some of these products in import alerts, which are stopgaps at the borders. So in that sense, that also can stop import of contaminated products, and it also has resulted in national recalls. So it's, again, it's a collective effort. Hope that answers your question, Valia.
Thank you for that. And one of the other things that we've been thinking about is, of course, if you stop the import of those products, does it then just get imported somewhere else, or does it get mixed in? If it's food products or something, would it get mixed into other batches to reduce the exposure? So one of the things that we're thinking on, and that this coalition will also start thinking on, is how do you trace back those contaminated products to the producer or the farmer who actually produced it, and those sort of things. So lots to definitely think about here, a lot of interesting strategies for us to discuss. This is the beginning of the conversation around lead. There's plenty of work to do, so thank you all so very much for participating, for the active chat. The session has been recorded. We will be sharing that and distributing it. If you are not getting our newsletters, please do sign up or check your spam. Sometimes they go there. We look forward to engaging with you all together. And if you're interested in sources of exposure in Africa, tune in on Thursday. Thank you so much, everyone. Have a good day.
Thank you.
Thank you.
Thank you very
Bye.
much. Bye-bye, everybody.
Thank you. Bye.
Bye.
Thank you.